Hello everyone. Today let's discuss on our another important short notes, that is diagnosis and treatment of our Kawasaki disease. So this is an easy topic. If you would have seen many cases in your pediatric ward with the Kawasaki disease. So you would have read regarding Kawasaki disease from top to bottom from your Nelson. Okay, but there is a very important question that you should not make even a single criteria mistake. Okay, so that I'm taking it here in this on our YouTube channel. Okay, yes. Starting with the introduction, Kawasaki disease is also known as mucocutaneous lymph node syndrome. So it is also known as mucocutaneous lymph node syndrome. Next, it is an acute systemic vascular disease which mainly affects your medium-sized vessels, right? It is your acute systemic vascular disease that mainly affects your medium-sized vessels. So that mainly affects your medium-sized vessels. That mainly affects your medium-sized vessels, but there is a predilection for coronary arteries. So they mainly have predilection for coronary arteries, right? Yes. Here, around 20 to 20% of these children who are left untreated, they develop. So untreated children with the Kawasaki disease, where they develop your coronary artery abnormalities, while compared to less than 5% of the children who are treated with your IVIG will develop a coronary artery abnormalities, while less than 5% of the children treated with IVIG develop coronary artery abnormalities, and this is the most common cause of acquired heart disease. So most common cause of acquired heart disease in children. Next, going on to the diagnosis. Diagnosis is always a clinical diagnosis only Kawasaki, and you need a clinical criteria for this. So clinical criteria is child with fever for more than or equal to 5 days with 4 of the other other following criteria. Among the 5 things, that child should at least fulfill 4 of the following. The first one is your conjunctivitis. The conjunctivitis is usually bilateral with bulbar conjunctival injection without exudate. So here it is your non-exudative conjunctivitis. Next, second point is lymphadenopathy. It is usually your cervical lymphadenopathy, which is unilateral with a dimension of more than 1.5 centimeter. Third one is the child will go on to develop rash. Rash is your polymorphous rash. The child can have either maculopapular or a diffuse erythema rash can be present. So the child will develop a polymorphous eczema. Fourth criteria is regarding your oral mucosa and lips. The child can have red cracked lips with strawberry tongue, or the child can have erythema of your oropharynx. The child can have erythema of oropharynx. Coming to the changes that is present in the extremities, that the child in acute state, the child can have edema and erythema. Edema and erythema of palms and soles. While when the child goes to a subacute stage, the child will develop a typical peeling that is called as your periungual peeling of your finger and toes. Okay, so this is your main criteria which you should not forget to write in your exam, okay, and even for your practical purpose also. So this is the main criteria for a child to diagnose your what is this, Kawasaki disease. Next, when a child have an incomplete Kawasaki disease. So what is the meaning of an incomplete Kawasaki disease? So incomplete Kawasaki meaning the child does not fulfill the your criteria, but you don't have any other diagnosis or any other explanation for that fever, particular fever the child is having, then you can evaluate the child for your incomplete Kawasaki disease. That is, your child with fever for more than or equal to 5 days, and the child is having only 2 or 3 clinical criteria that we have talked earlier. Only 2 or 3 clinical criteria is considered as an incomplete Kawasaki. Or if an infant with fever for more than or equal to 7 days without any other explanation can also be considered as an incomplete Kawasaki disease. Why we are considering infant here is, so when the child and the infant is less than 6 months, so infant or less than 6 months mostly develop prolonged fever without any clinical criteria. So these infants are at very risk of developing coronary artery abnormalities. So they are at risk of developing coronary artery abnormalities. 1. Okay. So in this child you are going to do your lab investigation. In lab investigation, main investigation is your CRP and ESR. So coming to your lab investigation, when the child is having your CRP of less than 3 milligram per deciliter and ESR is less than 40 millimeter per hour, or if the child is having CRP than 3 or more than or equal to 3 milligram per deciliter, or if the child's ESR is then or equal to 40 millimeter per mercury. So these are the two main lab investigation you have to do. So you have to classify the child whether the CRP is less than 3 or more than 3. If the child is having a CRP or ESR of more than 40, then you will go on with the other investigations. In other investigation, if 3 or more lab findings, which I am going to tell, when the 3 or more lab findings come to be positive, then you are going to treat the child with your IVIG. So 3 or more lab finding meaning if the child is having anemia for that particular age, or when the child's platelet count is more than or equal to 4.5, that is 4,50,000 after day 7 of your fever. Third, when the child's serum albumin level is less than or equal to 3 gram per deciliter. Next, if the child is having elevated ALT level. Fifth, if the child is having a WBC of more than or equal to 15,000 per millimeter cube. Sixth point, if the child's urine protein shows more than or equal to 10 WBC per high power field. So these are the among these 6 laboratory features. If the child is having any 3, then you consider the child to have your Kawasaki ongoing inflammation. Then you're going to treat the child. Okay. Or this is present. Or if the child is positive echo or any 3 of this following, then also you are going to treat the child. Fine. Yes. So what is the meaning of positive echo here? So what is, when do you consider the child to have a coronary artery abnormalities, or when do you consider a child to have a positive echocardiographic features of your Kawasaki disease? If any one of the 3 which I am going to tell is being present, then you can consider the child to have a positive echo. That is, first, when the Z score of your left anterior descending coronary artery, anterior descending coronary artery, or your right coronary artery is more than or equal to 2.5. Second, if more than or equal to 3 other suggestive features, other than your coronary artery abnormalities, other suggestive features which includes One is your decreased left ventricular function. When the child is having decreased left ventricular function. Second, when the child is having mitral regurgitation. Third, when the child is having pericardial effusion. Then you consider the child to have a positive echo. Or when the Z score of your left anterior descending artery or your right coronary artery is between 2 to 2.5. Then also you consider the child to have a positive echo. Then you start on a treatment for this child. Next, if the child's CRP level is less than 3 or the ESR is less than, and the ESR is also less than 40 millimeter per mercury, then what you do? Then you have to do a serial clinical and laboratory re-evaluation if the fever persists. So if the child is having fever, then you do a serial lab investigation. Yes, or if the child develops a typical peeling. So typical peeling meaning that peeling begins in the nail bed of the fingers and toes. If the child develops a typical peeling, then echocardiograph should be done. Fine? Yes. So this is the way you evaluate a child of your incomplete Kawasaki disease. Right. Next, going on to your investigation. We have everything here only: ESR, CRP, CBC, albumin, LFT, this WBC. Next, urine routine. So these are your main investigations. I'll write it once again here. So your ESR, CRP, LFT, albumin, your serum electrolytes, and your renal function test, and your urine analysis. Okay, these are the main investigation. Next will be your echo and ECG. Should be done whenever you suspect a child with Kawasaki disease. Echo and ECG should be done as a baseline investigation at the time of diagnosis. So it should be done as a baseline investigation at the time of your diagnosis. Next, third, when do you repeat your echo or ECG? That is intermediate echo. So what is intermediate echo? When the child's initial echo is normal and the child has fulfilled your clinical criteria for your Kawasaki disease and you have treated the child with IVIG. After 2 weeks of your initial IVIG, you take another echo that is called as your intermediate echo. The echo that is taken 2 weeks after first IVIG. 2 weeks after first IVIG, in whom your initial echo is normal. Fourth, again, when do you repeat the echo? So all the patients with the Kawasaki disease should undergo echo at 6 to 8 weeks after the disease onset to see progression. Okay. If the patient is having an ongoing inflammation, so ongoing inflammation meaning if the child is having an increasing or persistently elevated CRP, or the child is having persisting signs and symptoms of the disease, for that child you have to perform echo weekly basis. So echo should be done weekly to monitor for the development of your cardiac sequelae. So to monitor the development of your cardiac sequelae. Right? Yes. Next, if the child is having coronary artery abnormalities on your initial echo, then also the child should be monitored with echo at least weekly to know the progression. So if the child is having coronary artery abnormalities is be present on your initial echo, then also your child should be monitored weekly, right? Yes, fine. Next, going on to the treatment. Treatment, everybody knows it is your IVIG, immunoglobulin, given at the dose of 2 gram per kg as a single infusion over 10 hours. 10 to 12 hours you are giving this infusion. This should be given within 10 days. Should be given within 10 days of your within 10 days of your disease onset. But ideally, when should you give IVIG is as soon as possible once you diagnose this Kawasaki disease. So ideally, as soon as possible, you should give this IVIG. If the child is presenting you after 10 days of illness, the child is presenting to you after 10 days of illness with fever, persisting fever, or coronary artery abnormalities, along with elevated ESR and CRP, then also you have to start on a child with your IVIG, right? Yes. Next, along with IVIG, you should administer 30 to 50, it is a moderate dose, okay? 30 to 50 mg per kg per day. You can elevate to 80 to 100 mg per kg per day of aspirin should be given to this child until the patient is afebrile. That is for at least 48 hours. After this, you have to change the dose to 3 to 5 mg per kg per day for 6 to 8 weeks. This aspirin should be continued if the child's coronary findings, that is your echo finding, are normal throughout the course. Next, third, long-term treatment. So what is your long-term treatment for a child with coronary abnormalities? So if the child is having coronary abnormalities, your long-term treatment will be, you have to give aspirin. Along with aspirin, you will be adding clopidogrel at the dose of 1 mg per kg per day. Maximum you have to give 75 mg per day can be given to this child. Supposing if the child is having giant aneurysm meaning the Z score is more than or equal to 10, then you will start on the child with warfarin. Warfarin should be administered in addition to your aspirin. Okay, this is how you treat the child with Kawasaki disease. Next, if the child is having IVIG resistant. So what is the meaning of IVIG resistant? That is the patient with Kawasaki disease have developed recrudescence or persistent fever. Recrudescence or persistent fever at least 36 hours after end of their IVIG infusion. The patient with the Kawasaki disease have developed recrudescence or persistent fever at least 36 hours after the end of their IVIG infusion, meaning the child is having an IVIG resistant. How will you treat this child with IVIG resistant? One, you can give your second infusion of IVIG. Second, it can be, you can do high dose pulse methylpred. High dose pulse steroids, that is you can give high dose pulse methylpred, that is the dose is 20 to 30 mg per kg IV for 3 days can be given. Third, you can give infliximab at the dose of 5 g per kg. If the child is having a resistant to your second infusion of IVIG or pulse dose methylpred or infliximab, then you can consider the child with cyclosporin. Okay, so this is how you treat the child with IVIG resistant Kawasaki disease, and this is the method of diagnosing and treating a child with Kawasaki disease. And another very important point regarding the vaccination and Kawasaki disease with IVIG infused child, that is live vaccine, mainly your MMR and varicella, should be deferred. That is, you should be deferred for at least 11 months. Okay, should be deferred for at least 11 months after administration of IVIG at the dose of 2 gram per kg for Kawasaki disease. Okay, so live vaccine like MMR and varicella should be deferred for at least 11 months after the administration of IVIG at the dose of 2 gram per kg for a child with the Kawasaki disease. So this is the about your diagnosis and management of a child with Kawasaki disease. And thank you. This is a very important question for your university short notes and also for your NEET PG entrance question. NEET PG entrance also Kawasaki disease is an important topic. Thank you. Thank you so much for your patience listening. Next video I'll try to make on pulmonary function test or your enzyme replacement therapy. Thank you. Thank you so much.